Hello, welcome to another Wednesday, another adventure with our Move It or Lose It podcast. And today, I know many of you have been anxious about what does sleep and MS have to do with each other. So today, I have a guest, Abbey Hughes, who is a rehabilitation therapist, and she's going to talk to us about sleep and about some other things that we can really take a hold of. So I really want you to listen in, give me your feedback. I'm really excited about this podcast because I know for me, it's always been a struggle. And for so many of my MS patients, clients, this has been a struggle. So without any further ado, I'm excited to bring her on. So Abbey Hughes, welcome to Move It or Lose It podcast.
Hi, thank you so much for having me. It's such a delight and a treat to be here.
Thank you. For us too. So you started at Johns Hopkins how many years ago? 5 or 6?
Yeah, about 6 years ago.
Okay. So what drew you into the world of multiple sclerosis?
Well, I'm so glad you asked. And so my area of specialization is in psychology and MS, particularly in rehabilitation. So I'm in a special niche area called rehabilitation psychology. And a lot of my training to date has been within specialty areas of MS and working with patients and families affected by MS. That initially started pretty much as an accident. As I was a college student, I was a psychology major, neuroscience major, was interested in biology, physiology, and psychology, and the intersection of those topics. And I just happened to start volunteering in a laboratory as part of my undergraduate training that happened to be studying brain behavior relationships and particularly behavioral training in rodent models of MS and in spinal cord injury.
So I love that when I read that. I
yeah.
thought like, wow, it just followed this path. And so.
Yeah. So that was my first introduction to what MS was. And then from there, I realized that there were other people in my life who were affected by MS who I did not know at that point.
Right.
And so as I've continued to study and grow and go to graduate school for clinical psychology and specialization in rehabilitation psychology, that expansion grew both from the professional side and the personal side.
Right. And if I understand correctly, when you were there, you were also with a neurologist, right?
Yeah,
so you got to study with him.
Yep, I did my graduate training at University of Kansas, and my primary mentor also studied MS, and I was introduced to a wonderful neurologist, Dr. Sharon Lynch, in the Kansas City area with University of Kansas Medical Center. And just seeing her approach to integrating psychology and other rehabilitation specialists like physical therapy, occupational therapy into the practice of neurology was it was just such an important and different perspective that I hadn't seen yet before.
Right. I think we're all going to ask for her name after. So many of our MS patients at this point have been just frustrated with their neurologist, the lack of care, the difficulty getting in. I would say one of the biggest things are the giant wait lists. And then you get in and it's this unseen. It's like almost like a bother to be there. And the more you advocate, the more pissy they get. So it's been a big frustration that I hear a lot in the autoimmune world is the doctors and, where you have it, which I love at Johns Hopkins, where it's all there. So you've got we've got all of the neurologists, all the things that we need, the neuropsychologists, the neurorehabilitation, where here it's like you are in Michigan unless you're right next to University of Michigan, you literally are finding your own team piece by piece, if you even understand what that means. I mean, I'm 20 something years in and I know what it means, but so many of our newly diagnosed patients have no idea what a team even is. And depending on where they're located, I find it to be very difficult for them not having the tools that they need.
Yeah, absolutely. I mean, you're speaking to a problem that nationwide, depending on your access to comprehensive MS centers, fortunately, through advocacy organizations and training centers like Hopkins, like University of Washington, where I did my postdoctoral training, and others, there are more providers who are becoming passionate about this team-based care. So, and in more rural areas, finding that, seeing a local neurologist might be the only option for a lot of patients. So that's a huge growth area.
I love that. That's so important. And I also like the SciPact idea, which we've been talking about on several of the podcasts, is that, check your state, see if you're one of the states. Cause I think we're up to 28 states that are participating now. So praying hard for Michigan to get their stuff together and let's get it going. So I think that's going to be a big one, especially for our autoimmune patients that are not wanting to leave the house. They're still too nervous, still too big of a job. I know so many that are just having trouble still after COVID getting the transportation stuff settled, where they'll be waiting, they'll be late to their appointments, things like that. So I think this will be a huge thing. So I wanted to talk to you a little bit about now, what does this all mean? We're talking about, I wanted to go into sleep and how so many of us struggle with sleep, whether it's falling asleep, staying asleep, the times. And I know a lot of the culprits, the screen time, the coffee too late, the caffeine, all of the things that we do to ourselves, and doesn't make it any easier for us to sleep. So how did you get into this specific area with sleep, and what have you found?
Yeah, so in terms of interest, there's been a big need for addressing sleep issues in MS for a while, and I'm certainly not the first to observe that, notice it, or try to address it. And there's some wonderful, again, behavioral sleep specialists in the MS world who are also publishing on this as we speak. So my interest became in the intersection of sleep issues and MS, particularly when I was on my postdoctoral research fellowship at the University of Washington under the mentorship of Aaron Turner and Dawn Eady. Both are rehabilitation psychologists, neuropsychologists at University of Washington and at the VA Puget Sound healthcare system. And one of the main focus of their research is modifiable lifestyle factors, or problems like pain and depression in MS, and what are some psychological treatments or health behavior treatments that can be helpful for managing those conditions. And so there's many years of research supporting cognitive behavioral therapy for addressing depression symptoms, reducing depression severity, increasing, most recently, Dr. Kevin Alschuler has talked about increasing tolerance of uncertainty in MS. And certainly there's a lot to feel uncertain about with this condition. That can also contribute to sleep disturbance. So my little piece of that is trying to figure out what are some of the behaviors that help promote sleep, not just quantity, but quality sleep, in the presence of things about MS, some of which are changeable and some of which might not be changeable.
So I agree with that. And Abby, my question to you about that is that I can notice that let's say it's, I only got 4 hours of sleep, but if that sleep was quality sleep, and I really got into REM, which is very rare for me, then if I got into that REM part of my sleep, then I actually feel rejuvenated, rather than 6 hours, 6.5 hours of that, like up, kind of up, but I'm not really there. I'm not really sleeping. So how do you find that to be a really big issue for MS society, to really struggle with not knowing good habits?
Yeah, so habits are a piece of it. And if it's okay, I'd like to just share the 4 main reasons why people with MS are more likely to experience sleep issues. And this could be, as you said earlier, difficulty falling asleep, difficulty staying asleep, so waking up frequently in the night, and then waking too early in the morning. Those are 3 symptoms that that are part of a diagnosis of insomnia. When they get severe enough to interfere with daily functioning, cause severe daytime sleepiness, and when they're not caused by another known medical condition that is fully accounting for those difficulties, then that's where the insomnia piece comes in. And so within MS, there is damage to the brain for new lesions or maybe long-standing lesions that they themselves can affect areas of the brain that are important for our circadian rhythm. The way that we process light through our eyes, our optic nerve, can be very affected in MS, and that's an initial gateway into processing light and regulating that 24-ish hour clock that humans operate on.
I have a question when you go back to that, because this is really selfish, but I've had optic neuritis from the beginning. And so I've had a couple of years where I got the sight back, but my optic neuritis tends to have a lot of pain with it. So I get a lot of headaches from it. Bright lights affect me. So with the work that I do and training and stuff, there's always lights. And so I know that I can always tell when I've been in lights or I've been in the sun, which I'm loving, but I don't have the correct, sunglasses on to protect my eyes. So you said that. I've never heard that. So this is the first time I've ever heard that optic neuritis affects your sleep.
Well, this is a really new area. And in fact, I certainly can't take credit for this area of research. There's some growing research by Kate Fitzgerald and some other sleep researchers looking at circadian pathways in MS. And we're really trying to understand where it starts, where does it become more exacerbated, what are the other factors that play a role in that. So I can't speak specifically to your experience with that, but as you said, there's also pain, there's headaches, there's other things that may also interfere with our ability to fall asleep, right? If we have a headache or if we have light sensitivity, and when you get a headache, you go inside and in the dark for several hours, right? All of these things they're not the end all and be all of sleep, which is going to be a really important thing I want to emphasize today, is that any one single thing we do is really not going to destroy our sleep, but our belief that that is true is one of the more problematic things that keeps us up awake at night.
Yeah. I don't want to get ahead of you, but I am interested in that, in our behavior. So what are some of that you would call, like, let's say I came into your office, I came to meet with you, or praying Michigan will open up and I can just virtually meet with you. And I'm going over some of my issues with sleep. I would definitely say I have insomnia. So if I'm coming to you and I'm letting you know that, gosh, sometimes I get done with work and it's really late and I just need some veg time. So I might just want to watch a little TV for a little bit and just kind of like bring my body down. And it may be a little bit too late for me to do it, but my body's just telling me that I just need to have some like wind down time. And I may not want to listen to anything because I've listened all day to something, to people, to clients, and I may just want to not hear anything, just to kind of veg out. So how difficult is that for our bodies, our MS bodies, to go into that sleep place if we've been watching TV and it's, a half an hour before we're going to go to bed?
Yeah, that's such a great question, and it hits on kind of the number two aspect of what leads to some more sleep disturbance is our behaviors and our routines. And to some degree, we all have different ways of winding down from the day. And I know there's a lot of talk around bright light exposure or blue light from TVs and iPads and iPhones. And while there's some evidence to support that can be disruptive of our light processing, what ends up being more problematic about the use of devices or watching TV is not so much the screens themselves, it's the fact that shortly before we're trying to transition to bed, our minds are otherwise really engaged and activated for something. If we're staying up late watching the news, last time I checked the news, there was not much good happening. So that in of itself can drive some more worry and anxiety. Even just things that are really emotionally laden and driven, things that make us feel really intensely. It could be a wonderful part of experiencing a Netflix show, but bringing ourselves back down from that level of excitement can be a little bit more difficult. The bright side is it doesn't take long for us to bring ourselves down from that. And so to answer your question about if someone comes in to see me, often we have a conversation about what your routine typically looks like. And are you trying to rapidly transition from a state of really high arousal activation and then expecting yourself to be able to shut it off and turn, to fall asleep right away? That's not really a good expectation or reasonable expectation for any human being. We need about 30 minutes to wind down.
Exactly. So, I would say.
And so if you do end up finding that you are staying up late because you want to do those other activities, and that's the primary reason that you're not getting enough sleep, that's actually not insomnia. That's what we call reduced opportunity for sleep. You're not giving yourself enough opportunity for sleep. It becomes insomnia when you have enough opportunity, but then you're not able to sleep even when you have that opportunity.
So what I've done, and you'll have to say if this is good, because I know that I echo what a lot of our MSers do, is I will try to shut it off before, like about at least 30 minutes before. And that's when I'll have my wind down, go upstairs, kind of get my body ready. If I want to hear something, I might listen to some like classical music. begin to do some meditating, and then just kind of get my body kind of settled. And, and then sometimes it does, sometimes it doesn't. And then it is, for me, it's the waking up. And I know so many of us waking up several times, whether it's to go to the bathroom, whether it's to, somebody opened and there was light in, and then all of a sudden you're sensitive to the light or any noise, things like that can wake us up. And I think it just starts our mind going, and then we're up. So I think that's one of the biggest things I hear.
Yeah. So I think there were three things I heard there. One was that depending on where you are doing these activities to wind down, that could also play a role. And so we talk a lot when I'm working with folks around managing their sleep, is really saving their bed only for sleep and sex, or sleep and intimacy.
Yes.
And by doing that, instead of having this long list of all the things that our brain could be stimulated on within the bed, having it only be sleep and sex kind of gives it a less options, right?
Yeah.
And so that creates a much stronger pairing of bed with sleep. And so now when you get into bed, it becomes a signal for more sleepiness or more ability to fall asleep.
Right.
But even then, the next piece that I heard was around kind of how to wind down when you are starting to get frustrated.
Yeah.
And I think that's one of the biggest, and it's not my belief, research has shown that one of the biggest drivers of sleep and insomnia issues are often the beliefs about that. So let's say you're already living with MS fatigue, and that's already a significant thing that you live with from day to day. And then you have a poor night's sleep and you feel more fatigued. Then the next night, it almost puts more pressure on you, or maybe, I don't want to speak for you, but some people have shared with me, it puts pressure on them to, okay, I have to sleep better tonight.
Yes.
If I don't get 8 hours of sleep tonight, I'm going to be worthless tomorrow. Or if I wake up more than 3 times a night, gosh, I'm going to be so frustrated.
Right.
And that initial reaction too, even in the middle of the night of waking up and being like, oh, I have to go to the bathroom again.
Right.
Even that kind of that emotional piece of it, sometimes our mind starts racing and thinking about, this is going to happen, and this is going to happen, and this is going to happen.
Right.
And so part of, again, where psychology and psychological treatment comes in is to isolate what are those thoughts that do come up in the middle of the night. Or what are you doing with the thoughts when you can't sleep in bed? Are you getting your phone out? Are you reading? Are you just sitting there thinking about your to-do list for tomorrow? All three of those things are not sleep or sex. So taking those out of the bedroom or out of the bed, we also talk about just doing safe transfers from the bed to a chair by the bed. People have mobility issues, just to create a separation from bed and those other places.
So what I've learned, and you tell me if this is right or wrong, is that if it's been 15 minutes and I'm still wrestling with myself, in bed, trying to figure out what's going on, that I'm getting aggravated, I will just exit. Like you said, I'll leave and either, again, meditate, do something away from the bed so that I'm not frustrated in bed. Then when I feel myself feeling sleepy again, I'll go back to bed. So is that something that you suggest to do?
Absolutely. I mean, you're right on the money. And the reason for that is you start to break apart that association of not being frustrated in bed. You have your worry time, you have your frustration time outside of bed, allowing yourself to kind of calm, bring back to that sleepiness. And the other part, I often will, when I'm working with people, I hear, okay, but I tried that and it didn't work, or I was still really awake, or I ended up staying up the rest of the night. And I don't want to say good, because it's not a good thing that that's happening, but what you're doing is you're creating this almost like balloon of sleep pressure, and you're putting more air in the balloon. That the goal is not for you to fix your sleep tonight. The goal is to start creating relationships and habits that are going to be more effective for you tomorrow night. So even if you don't sleep at all tonight, or if your sleep is really poor tonight, by getting out of bed, doing something else, you will feel sleepy. You will probably not feel on your game the next day. But by the time bedtime rolls around the next night, you've started to create this other pattern that's more likely to maintain. So it's kind of like instead of chasing the sleep, you're allowing the sleep to chase you.
I love that, Abby, because I had a talk with one of my clients, and I said, one of the things that I try to do is, if that night, like you said, it just wasn't happening, I just wasn't getting a good night's sleep, then calm myself down and know that this is going to make me sleepy for the next night. And like, you're right. Like, I may not be on top of my game that day. However, if I can just look forward to the next night, that I am going to sleep, And this night may not have been the best night, but then kind of calm down the stress and the anxiety of, oh my gosh, how am I going to get through this day? And just breathe and say, you know what? I may not have 100% day, but I'm going to do my best, get through, knowing that I'm going to be tired tonight because my body will give in to sleep. So I think those are all really important things that we tend to do and get really aggravated. And instead of just, okay, breathe, it's going to be okay.
And as you're talking, I also want to be mindful because I'm almost imagining if some of your listeners are thinking, yeah, but my bladder wakes me up. And it's not, maybe it's someone who doesn't have anxiety and they're still having difficulty falling asleep.
Right.
So I don't want to dismiss all of this as being related to depression symptoms, anxiety symptoms, et cetera. That could certainly be a piece of it. And working with a psychologist can also be helpful for identifying those unhelpful thoughts that perpetuate insomnia.
Right.
A whole other piece of this with MS is managing the MS symptoms. You might have restless legs. You might have sleep apnea. You might have chronic neuropathic pain that wakes you up in the middle of the night. So and those are also treatable through behavioral strategies. And you also want to rule out other physiologic causes of sleep disturbance. And so another piece of that is, in addition to working with a psychologist, working with a sleep physician or a neurologist who can help you get connected to a sleep specialist, because for some people, a sleep study would be really appropriate for determining if you have sleep apnea, which affects about a third of people with MS. I believe Dr. Braley at University of Michigan has some research in the prevalence of sleep apnea in MS. And restless legs is also it's more common in people with MS than the general population. So that's part of working with a behavioral sleep specialist can be about not just saying, oh, stop worrying, because that's certainly not what we do. That is certainly not the way to help people stop worrying. But rather acknowledging that these are some very real, really disruptive physical symptoms that people with MS experience that are unpredictable. And how can we partner together to have those symptoms be less disruptive to your life? And some of that may mean sleep apnea treatment along with some behavioral strategies.
Yeah, I love that. And I agree 100% because there are times that, it's not psychological or anything like that. It's not depression, like you said, or anxiety, but it is just those MS things like the spastic legs. Sometimes my spasticity, and I know several others, just gets so bad in different areas, whether it's our forearms, our legs. And then it's like, you're up again. And then having to go to the bathroom is very common for a lot of us. So having to go to the bathroom and having any light, gets you, it just all of a sudden, it kind of just messes it up. You could be having a great night's sleep and then all of a sudden there it is again. You're tossing, turning, trying to like hold off going to the bathroom as long as you can. And then it's like, okay. So I think that's a big piece of it. And I think a lot of us would benefit, but I would say, Abby, if you agree with this, that a lot of MS patients don't know that stuff is even accessible, that a therapist like you or like the ones that we're talking about are even accessible to us.
I would agree. I think just even knowing that psychologists like me, like my colleagues, like there's a whole field of health psychology, neuropsychology, and rehabilitation psychology who focus on living with a chronic health condition, disability, advocacy, the intersection of those areas in healthcare systems. And a lot of us do have experience working with people with MS. And so I know with Megan Byers' Find Empathy initiative, that's one thing that she's trying to help patients connect with a psychologist who has some knowledge, potentially some personal experience as well, with people with chronic health conditions. So I'm glad that you're also raising awareness of this. And I also would just encourage people to, if you're Googling through the National MS Society, through Can Do MS, all of these sites do have some really great sleep resources there. As is the University of Michigan's My MS Toolkit has a whole subsection on sleep too. So it's such an issue where it's out there, but people aren't necessarily aware of it. So I just want to keep repeating what's out there.
Exactly. I feel like I'm repeating it often. It's one of the main reasons I wanted you on today is because I think people know they're there, but it's again, forgetting. I think we're still dealing with so much of our autoimmune community and our MS community is just getting back that cognitive that so many of us have really felt that we've declined from COVID, from the pandemic on, and trying to get that back and stuff, and trying to feel like, like just things are somewhat normal for us health wise again. And so I think that that's a big one. And I'm so appreciative of of you continuing to repeat that stuff. And as I think we were on the same podcast on the Find Empathy one, on it was movement. And then we talked about sleep and insomnia and things like that. So that's one of the big reasons I wanted to have you on. But I'm reading some of the notes, some of the questions I asked you. And so as far as like, let's say they're coming in and they're on how much medication that our doctors like to give us. So, we're coming into you and we've got, loads and loads of our nighttime cocktail medications that have been given to us. So how do you, because I know for some, it makes them nervous to think I couldn't sleep without this stuff. This is crazy talk. How do you begin with a patient that is only known sleep medication?
Great question. And actually, this is the third of those 4 reasons I talked about of what can contribute to insomnia. Medication side effects can also be a factor there, just as you said. And so this is where, again, I'm a psychologist. I don't prescribe, nor do I make any recommendations about whether to start, change, or stop a medication. And partnering, therefore, with a prescribing physician is such an important piece of this, because I might know that a certain medication has a side effect of activation, right? Like increased energy. So a lot of patients with MS might take a stimulant medication for any number of reasons, or a medication that has a side effect of feeling more energized or jittery. Sometimes people experience it that way. And so sometimes the timing of those medications can be helpful for making it so that you have more of that energy during the day,
right?
And it becomes less of a barrier at night. So sometimes that's one approach. There can also be medications that have more sedative effects, and whether they are specifically to help with sleep or if it's a side effect, that's always one thing I'm curious about. So if someone might say, I'm on this medication and it makes me really sleepy, my question is, was it prescribed to help you with sleep, or was it prescribed for a different reason? And if it was prescribed for sleep, again, I'd want to go back to that provider and say, just have a conversation around, we can still do some behavioral therapy, and I'm not managing the medication side of things, but there is a large body of research that supports that when people change their behaviors, this is not MS specific, but for people with insomnia that doesn't have a medical cause, doing cognitive behavioral therapy for insomnia does reduce the reliance or frequency use of sleep medications.
Yes.
Yeah.
So I think that, as I talked about, there's a lot of MS patients that do still want to take their sleep medication. Then you've got another side like myself who's saying, over medicated, I need to get rid of this stuff. It's too much. I need to get rid of it. But then I need that other piece, someone like you, to step in and say, like we all do, to say, okay, where do I begin? How do I begin to stop? And if we don't have a neurologist, and part of my podcast is that it's okay to break up with your neurologist. If he's not hearing you and you're saying this over and over again, and he's still prescribing you more sleep meds, that's a big red flag. It's time to step out. And I think that it's so important to be with someone like you, because like I know for myself and so many, it is like, I've got to get off this. This is just too much medication and no one's hearing me. If I go to a doctor, they're just putting me on a new one, a different one. And so we get a lot of that in the MS world, where it's just prescriptions. And so then all of a sudden, if it's during the day, we may have a little bit more strength. And then all of a sudden at night, our sleep is even more messed up. So I think it's a big thing, is having a team of psychologists and stuff to go through what exactly are we on, and how can those begin to be taken down, and having better ways to learn to fall asleep and stay asleep.
Sure. I mean, you said something there. I love the idea of breaking up with a provider, right? And not just a neurologist, but psychologists too, right? I'm certainly not everyone's cup of tea, and being able to say, you know what, this is just not working for me, or
Yeah.
here, I've expressed my needs and my needs aren't being met, and here are my concerns. That definitely is such an important part of being a patient advocate.
Yes.
And it's your life, and you're at the center of that hub. To your question about, let's say someone's been using a sleep aid for a long time, whether that's something over the counter or something prescribed, I take a pretty flexible approach where we know that for insomnia, the gold standard treatment that's recommended by the American Academy of Sleep Medicine is cognitive behavioral therapy for insomnia as a first line treatment. And the other medications were often developed based on basically being able to sedate people, but not necessarily mimic sleep. So a lot of medications might help people fall asleep, but doesn't necessarily help them stay asleep.
Right.
And it's the other part I want to rewind to is you were talking about REM sleep and non-REM sleep. And one thing I wanted to clarify is that when we go through different sleep cycles throughout the night, we go through periods of really shallow sleep and then deeper sleep. We come up to the shallow sleep and then we go into REM. And if you wake someone up during one of those stages, we usually don't know what stage we're in. We are very poor as human beings, not in MS specifically, but as human beings, we are very poor at judging our own sleep.
Yes.
And how asleep we were is often based on that stage of sleep, and all of the stages are important. And so it can feel like you can be in a shallow stage for a while, be woken up during that stage and say, what are you talking about? I was awake. And you might have a partner saying, no, you were definitely asleep.
Yeah.
And then similarly, you could be woken up in a really deep phase of sleep, and it's actually hard to wake you up and you feel more groggy, even if you got enough sleep. So sometimes when you get woken up, our perception of how well we slept is based on whether that stage was interrupted or not.
Yes.
So that piece, and back to our conversation about the medications, would be, in some ways we don't know what the medications are doing in terms of your cycle. And it's really about a goal that if your sleep, even with the medication, has been really disrupted for a long period of time, if you've been living with this for years, I might just ask about your openness of, would you be willing to try something either in addition to your medication or in partnership with your doctor if you want to make changes to your medication, having a conversation with them about that.
Right.
And then continuing on with the behavioral piece while that's going on. Because the behavioral piece is also very challenging. As you know, with prioritizing exercise and physical activity, any kind of behavior change is difficult. But I say if you can get through this maybe for 4 or 5 sessions, or 4 or 5 weeks of this kind of sleep boot camp, which cognitive behavioral therapy for insomnia can sometimes feel like boot camp, then you can actually know how bad it could be, and are you willing to tolerate that for a period of time with the potential that things could get better, or they could stay the same. They're unlikely to get worse in the sense of it's not going to make your MS worse. If your functioning in daily life is a little bit worse for a short period of time, that would be completely reversible. So it's a low risk and potential high reward for taking that approach.
See, this is all very exciting to me because the idea, like we talked about before we pushed record, being diagnosed so early in the 90s, it was, like we talked about, it was bags of steroids every time you had any sort of we didn't even talk about pseudo relapses then. It was just, you're in a relapse, here's your, 5 rounds of steroids and here's your Ambien, good luck to you. And little did we know back then, it was just the doctor said, and so we did everything we were told. Little did we know, looking into the future, how difficult those things would be to get off of. And so those are really difficult things I find with our patients that were diagnosed a long time ago. And I know for myself, I'm at a point where I'm like, I want off of this. So the therapy is such a big deal to me, and something that I'm really looking forward to getting into is to get into ways that I can, and I get what you're saying, it would be a boot camp for a lot of us, but I guess it's that deciding, is it worth it or not? Is your sleep worth it? If 4 weeks, if it could get better, is just such a great promise than having years to look forward to, or now look forward to, of more medications. when we could like start to begin to understand what it is that's keeping us awake and begin to understand our bodies and ourselves more with the help of someone like you.
Yeah, well, I really appreciate your insight into that, and just being open, right, to acknowledge how this might be hard, and willingness to experience discomfort, right? Our willingness to be uncomfortable and sit in that discomfort or sit in that sleepiness that comes when, let's say you're used to getting about 5 hours of interrupted sleep per night. And then after the first week of treatment, maybe you're getting even less than that.
Right.
As the treatment starts to take place. And I will say for folks who are on the fence, or maybe you're so far from the fence, you're not even taking a look at it. The online resources, if you Google CBTI, the Society for Behavioral Sleep Medicine has some really nice explanations for the rationale for this type of approach and treatment. And importantly, that it's not for everyone. It's not a one size fits all. There are some important medical and physiologic things to rule out to determine whether CBTI would be appropriate. And again, that's part of working with a sleep specialist and a behavioral sleep medicine specialist to determine what are those strategies that will be most effective.
Right.
So as an example of that, you mentioned steroids, and if someone has had a recent MS exacerbation and treated with steroids definitely disrupt our sleep. They're really important for calming down that inflammation and reducing the risk of other damage to the nervous system. So they certainly have their place and are such an essential part of MS management or MS disease management. And because it messes up our sleep, or it can really disrupt our circadian rhythm for a short period of time, if someone has had a relapse in the past 30 to 60 days, I usually say, why don't we wait it out and hold off and see kind of how your body adjusts as you're adjusting and recovering from this relapse. There may be other, maybe a physical therapist is something to really focus on right now.
Right.
And getting, working on the mobility piece.
Yes.
And we all have limited time, and I don't want to overwhelm people with all the treatments.
Yeah, no, I agree. That's something that I will do. I just had one of my clients with MS have a relapse. So as we have gotten through this, it's not going to be as much movement as it is stretching, as it is kind of getting his body ready to just have some stretching and just to get the body kind of moving in a different way. So we might not try to see what our legs can do, connecting and doing functional movements to get our drop foot to work on that, or to get the legs or the arms or whatever we're doing. We may do some more, that time may be 45 minutes of just stretching different parts of our body and just kind of waking up the muscles, but without putting too much on them when it's been after a relapse or things like that. Or honestly, Abby, when sometimes the clients are just having a really bad couple days. And so heat sensitivity, it might be just a few hot days. And so they're feeling like I may not be able to do this, but can absolutely, let's change course and let's do some more easier things that are going to help you and make you feel alive and awake without having you feel like, oh my gosh, what did I do? And the other thing too, is I would say for me, I always make sure that the clients are doing this nowhere near bedtime. So it's not something exciting them and keeping them up.
Yeah, and that's a great part. That's a whole, the behaviors and the routine often goes in this category, this big umbrella term called sleep hygiene, which is exactly like you said, of exercise or physical activity and movement is so essential for maintaining our circadian rhythm that we need to be active, right? Just as human beings, we need to be active.
Right.
And in whatever way that means for us and our bodies and our conditions and whatever we're able to do right now and we're willing to do. And if it involves increasing our heart rate, particularly if it increases our body temperature, trying to be finished with that activity about 3 hours before bedtime.
Yeah.
Especially if you have a harder time cooling down.
Yes.
Sometimes we'll also talk about maybe taking a cooler bath or a cooler shower before bed to help bring that body temperature down, if that's one of the things that you find is making it difficult to fall asleep or get comfortable at night.
For sure. I agree with that. So give me, just for fun, what is like the worst case you've had of someone doing horrific things before bed in our MS community that you're like, wow, this is going to be one for the books?
Oh my gosh. I will I think by the time people come to see me, they've already tried so many helpful things that
Sure.
I'm sure it's not even, I'd say it's non-MS folks that have some of the worst sleep habits. Um, I guess I think we are, especially in pandemic,
Uh,
we are in many of us are in survival mode, living day to day, just trying to do what works for ourselves, for our families, and we end up kind of living that survival mode day to day to day. And that in of itself becomes a bit of a habit. So whatever survival mode looks like for you, that could mean for some people they've increased their alcohol use or they're
yes.
smoking and as a way of coping or a way of trying to help them sleep. Maybe some have, again, as a way of trying to fit it all in, they've overscheduled themselves so they don't have an opportunity for sleep. So there's really nothing, I wouldn't say things that are so like egregious that are even worth a story to say, but rather just things that are, we're all human beings and we have things
Right.
that we know are probably not going to be helpful, but we still do them because it's serving some function, right? And
Sure.
as soon as that function becomes maybe less important, or we can figure out a
Yeah.
way of still meeting that need without the more unhelpful behavior,
Right.
then there's hope for getting a win-win, right? Getting what
Right.
you want with a more adaptive or more helpful strategy for it.
Right. So I like that very much because I know during the pandemic and certainly during the shutdown, I think a lot of the MS patients felt very isolated, obviously, very alone, very afraid for many reasons. But I think that sleep definitely became an issue more so than ever. And I think I'm still finding in the MS community a lot of us that have not gone back to a normal sleep cycle where eating has been pushed off to later and the wind down time has been pushed off to later. And so we're still in that. And I want to say, I would say for the MS community and a lot of the autoimmune community, it's that feeling that everybody has gone back to some sort of normalcy. And we're still like, wait, we still need, depending on the medication, we still need to be very masked and very careful. So it's even a bit more of an isolating time that I'm hearing a lot of the MS and the autoimmune world saying that now that everything's open, it's almost as if we're back to being invisible again, either invisible or a problem when we go somewhere. So help the listeners understand that as far as the sleep and what is the first step in coming to someone like you.
Yeah. Well, I appreciate you just sharing that. And I have heard similar experiences from patients and from others in the MS community, just describing those feelings of isolation and
Yeah.
the fear, right? The fear of being immunosuppressed
Yes.
while there's still risk of infection and what that means, and the uncertainty of figuring out what risk am I willing to tolerate or
For
prioritize
sure.
given other goals in life.
Right.
So I wanted to take a second to acknowledge that. And
Yeah.
in terms of where to start, again, everybody starts in a different position. I've had folks who've come in who said, I've never slept well, or ever since adolescence, I haven't slept well. I've tried XYZ, and just understanding what's been tried. And I've worked with folks who come in fairly new. They said, I always slept well. And then I was diagnosed with MS, and then I hit menopause, and now I can't sleep. And
Yes.
menopause is also a huge piece for women. And as they're navigating that piece and figuring out,
Right.
is this MS, is this hormonal changes, working with an endocrinologist, and those parts too.
I think that's a big one, Abby. I was going to ask you about because I know a lot of the women every month we do. It's called Wind Down Wednesdays, and so I have some of the women that are just actually Megan came on one time, and I have a lot of the women that are fairly well known in the MS community. Just come on, and the last time we talked about hormones and how that affects so many different areas of our life, but how that affects our sleep. And really, when we're in all ages, but when we're coming into that premenopausal, that stage, how then again, it affects it in a much different way as well. So I'm glad that you touched on that because I think a lot of women who may not be in menopause, but that are starting to have, periods that are not, that are kind of off all over and they're starting to feel like hot flashes, things like that. are not really sure where to go. Do I get on, a specific hormone therapy? And then, oh my gosh, my sleep is affected again. So I think that's another time that women come to where their sleep is just very much affected.
Mm-hmm. Yeah. And to be honest, that's not my area of expertise regarding menopause and how that affects sleep specifically, but it's on the list of asking,
Yes.
What is your status? If you're not in menopause, when did your mother start menopause? If you know, is that a factor to keep in mind and ask your PCP about? And if again, going back to the medication question, if you've recently started some kind of hormone therapy, it wouldn't be unreasonable to also see changes in energy level, sleep, as part of that.
Right. Absolutely. I've seen a lot of that. I'm looking into some of the therapies that are better for us, better for MS patients than some of the other ones that may not affect our body quite as well. So I know that's not your expertise. So now I asked you this giant question. So I'm going to have you explain it to me. So, because I'll probably get the words wrong. So I wanted you to have our listeners understand, in using the multidisciplinary I'll get that word wrong.
Mm-hmm.
And
the biopsychosocial approach.
Yes.
Mm-hmm.
So when I talked about how does it help you? So you can take that and break it apart. You can take the multidisciplinary refers to, so that people know that when they see it, they're not like, what? So explain what multidisciplinary is.
Multidisciplinary means that there are multiple disciplines or multiple areas of healthcare expertise that are all coming together as part of a team in team-based care. And that might look different at different kinds of health centers. It could mean that they're physically located together in the same hall or the same center, or it could mean that they're part of the same network and they know to refer to each other to have that comprehensive care approach. And so in MS, there's probably 20 different providers that could be part of your MS multi-D or multidisciplinary team: neurology, psychology, psychiatry, nursing, physical therapy, occupational therapy, urology, the list goes on. But the idea being that MS is not one problem, right? And it doesn't affect people in the same singular way. So it does take a team-based approach.
Right.
In a similar vein, the biopsychosocial model of care has also been around for about 40 years now. And it's the idea that, there's biological factors like our physiology, our genetics, the physical things that we can see and hear and measure, combined with the psychological piece, which is how we feel and how we think, right? So the cognitive piece goes into the psychological piece. And the social part of it is, how are we functioning socially? That could include employment. It could include quality of our relationships, maybe everything from intimate partnerships to community-based organizations and our identities. So that biopsychosocial approach just acknowledges that we all have, there's different factors that play in a role in managing MS. And so you have medications that help address symptoms and stop disease. You might work with a psychologist to assess your cognition, identify what are some helpful or unhelpful health behaviors you're engaging in and how to change those behaviors, or to treat depression or anxiety if that is also something that you're experiencing. Or coping with a new diagnosis. One does not have to have a diagnosis of depression to still benefit from working with a psychologist, like a rehab psychologist.
Right.
And then the social piece is, again, how do you interface with the world? What are your identities? That everything from cultural to community and how we interact in our relationships. And sometimes those stressors these are the systemic issues, right?
Yes.
And even beyond biopsychosocial, that model, again, that's quite a bit dated now, has expanded to really acknowledge the systems in place, right? You as an individual are not, at fault or fully responsible for everything that's happening. You exist within a system that has its own strengths and weaknesses too.
Yeah, no, I appreciate that, because we have so many newly diagnosed that even I do a support group called Women Who Disrupt MS. And in that support group, so many of the women come on and they talk about those things. There's a lot of newly diagnosed patients, and this is so new for them. To bring, like you said, to bring all of it on at one time, it can be overwhelming. But they do know that all of a sudden my sleep is interrupted. I'm not sleeping. And, I can look back and think, for myself, years and years ago, it's part of the grieving. It's part of the acceptance. It's part of the understanding, what in the world do I have? How's it going to change my life? And so you're right, the team approach that so many of our newly diagnosed, unless they're in a certain area, don't understand the team approach. They feel like, okay, I have a neurologist. I don't really like he or she, but I have one. And then they really feel that that's it. That's all they know they're supposed to have. So a big part of this for me was introducing, no, there's a lot more to this. And in order for us to live the best life we can live, there really does need to be a team. And sometimes it's more difficult because we have to kind of put that team together. And other times it's easier because, if you're near Johns Hopkins, you've got it right there. And so if you're near the University of Michigan or Cleveland Clinic, you've got your team there. So give some advice, if you would, Abby, to our newly diagnosed patients that are just terrified of the diagnosis and they're not sleeping, and where do they turn to? Give me your opinion of the spot they turn to first.
That is a big question. Again, I think I'm going to say it depends on the individual, because like you said, not everyone who gets this diagnosis experiences fear as an immediate reaction. And in fact, this is really where resilience and different coping strategies come into play. Sometimes MS is not the worst thing that has ever happened to someone. Right. But you specifically asked about for people who do feel overwhelmed, for people who aren't unsure where to go. And there are some nice initial education resources through your podcast, through the National MS Society, through CAN-DO, of kind of like you're diagnosed, now what? And I tend to take it as it can be like drinking from a fire hose if you're trying to absorb all the information at once. So one approach could be to take a step back and think, without the MS in the picture, what are your values in life? What are the things that are most important to you in life? And there's even, if you Google value activity, there's some checklists where it's a list of 20 to 50 different things that you can rank order based on what's most important to you. And for some people, that's knowledge, right? I want all the knowledge I can get. Right. For some, it's family. I want to prioritize my family. Depending on where those values lie, that can help direct you in what kind of information you gravitate towards. Like, let's say if family is a really important value to someone, then maybe having a session with a family member at the next neurology appointment would be helpful, or sitting down and watching an MS video together as a family, so that everyone's taking in information all at once. And again, just depending on the person and their speed, finding something that's a good fit, and not, if you feel discouraged after the first website or the first video, that's also totally understandable. That, again, not everyone's delivery or style might be your cup of tea. Right. So allowing yourself to pause and then try a different source. Yeah. Within this list of validated or valid news and information and science sources. Right. So I at the end of the day, it's letting your values guide which way to go, because I could give all the information about behavioral sleep medicine to someone, and they might say, okay, that's a lot. I don't think I'm ready for that. And as opposed to more a slower self-guided introduction to it. Yeah,
no, I like that, because I do feel like back when I was diagnosed, it was 2 videotapes. These are the medications. You've got 2 choices. Here's your life, here's your handicap sticker, and you'll be in a wheelchair in probably about 6 to 9 months. And you can go on a brisk walk. And so it was like, so it's exciting to hear now that when our patients are diagnosed, they're not that grim, those details that like life is over and here's a stroll that you can take. And so it's very
such an ableist perspective around like how defeating and how that like disability and
was.
therefore somehow like your life is over.
Yes,
So
definitely back then. It was extremely depressing because you didn't know what it was you had. No one really understood it. And that was really it. It was like, life is over. Here's your sticker. And I tell this story all the time. The first support group I was invited to was that, and I was newly diagnosed, no leg issues, nothing like that. And it was in a scooter shop. So I'm like, nothing like having everybody depressed, looking at outside of the shop, seeing all the scooters that they've already been told that, eventually they'll be in. And I'm like, this is not a support group that I want to be involved in. So I think that, as we talk about cognitive therapy and stuff, when you're in a support group, it's really finding a support group that's actually supporting you and finding, people around you that can help you with that positive attitude and not going to places that make life more fearful than it already is with the diagnosis.
And that's also such an important thing that I think providers can do on the front end where, when you see a scooter shop, it could also be a symbol of mobility and saying like that this scooters are a point of access, right? That now you can do, maybe if as mobility declines, there are options for staying active and staying mobile and having access to places. Right. So again, just acknowledging that how that ableist perspective really pervades our culture and our life, so that if we do get a diagnosis that could change our mobility status, how to have a provider that helps frame this up as you can still pursue the things that are valued to you and that are so important to you at different levels of mobility.
Yes.
And with that in mind, it takes some of the fear out of it and brings it back to, okay, in the same way that, as we live throughout our lives, we're constantly changing, right?
Exactly.
I'm the same person I am now, but I certainly don't have the language. I didn't have the language abilities at age 3 that I have now.
Correct.
And the words. So in that same developmental model, we all grow and change and have different reactions to these things. And that's not to say that there's not grief when we lose ability to do something we used to do. There's absolutely a grief process with that. But like you said, the fear or that message of disability or MS disability equating with loss of life or loss of agency, that's one thing I certainly try to fight against.
Yeah, definitely. And much appreciated, because I think it's something that I see a lot in. And so I'm going through some of the things. So Abby, when you started Johns Hopkins, what was the first thing that you really were passionate about, that you really wanted to see changes in?
Oh man. Well, in some ways, the sleep. I've really had a privilege. I'm relatively early in my career, being here for only 6 years and growing this research program that I've mostly focused on sleep, behavioral sleep management. And another big study that we just published was around emotion regulation skills. So learning how to cope with really intense emotions, particularly with a support partner. So that could be, the study was people with MS and their support partners together learning skills for managing complex, intense emotions when they occur.
Interesting.
And that trial was comparing this evidence-based treatment called dialectical behavior skills with, I'm gonna have to start that over. I said it incorrectly. Dialectical behavior therapy skills training.
I'm glad you had to say that and not me.
And so having an expert in DBT skills therapy, which I am not an expert in, deliver that intervention compared to a traditional peer support group.
Right.
And how learning how to build those skills really helps us manage those difficult emotions that come day to day, whether because those emotions are because of something frustrating about MS or because something frustrating our kid did that we didn't have the patience for that day.
Right.
I think that those are my main areas of work, and one thing that I'm continually wanting to grow is those kinds of treatment programs.
Yes.
Programs.
I love that, because for me, my caregiver is my husband. So I think that's so crucial. And I know so many, one of my podcasts is going to be 3 different couples, and their support person is their significant other. And I think that adds a much different element to your relationship. And I think that I do believe there is not enough help out there for the caregivers, and especially when it is an intimate relationship. And I think that it's something that needs to be just looked at much more, and much more counseling for not just the caregiver, but for both of us. Like you said, when those emotional and that when our anxiety goes here, like most of us happens throughout the day. I think that it's so important to know how to deal with that together. And so I love that that's starting, because I have not heard about anything like that where you can work together with your partner doing that.
Well, and that if any of listeners are working with a therapist, sometimes couples therapy is a great thing to ask about. Usually it's not with the same therapist because you've built this personal relationship and you might have a different therapist. But the skills training, the study that we finished is over, so it's not an active ongoing thing that we're offering in our clinic, but the idea would be just to continuing to provide education and access around couples therapy or more group-based skills training where you can bring your partner into a session.
Yes.
So there are certainly times where I have a single patient is the patient I'm working with, and sometimes their partner or child or parent or someone who plays a role in their life comes in with a very specific goal in mind of how to help manage their MS more effectively, or how to cope with their own piece of it.
Absolutely. I love that. I hope to see that coming, like it's actually going to be something that's provided. So we did the study. So that's what, phase 1. So there's usually 3 phases before they can actually bring it out.
Sure. So the study was published. It was a pilot trial.
Okay.
So there needs to be more research to continue to support its efficacy, but that doesn't mean that other therapy groups might not offer DBT skills training. And you don't necessarily have to it doesn't have to be an MS focused group, right? That it could be, again, just knowing that how chronic illnesses are so prevalent within the population, it would probably not be unusual to go to a group and meet someone else who has MS or another neurologic condition or chronic pain or some other piece of it that you can connect on.
Yeah, no, I love that. I think that's so important. And you've given some really, really important just reasons and things for us to look at besides just the medication, but what are some things we can do? And I know we don't all have access to you, Abby. I wish we did. I wish I could just come to you tomorrow and say, help. So what is your suggestion before we end? If someone is listening to this, and I hope that they are, and I hope that they're thinking, okay, I can breathe. There's other options than just being medicated. There's some help for me on the other end. So where do they begin to find that in their team? So they can you said some things about they can Google different different therapies, but CBT I know is a big one, and I don't think that a lot of us even know about cognitive therapy. I think that that's something that anytime I ask my newly diagnosed, they have no idea what that is. So so their first step in going to that, where would you have them if Google is something that we're always told, don't go on Google. Don't go on Google.
Yeah, it's so hard because if you're Googling through, support chat rooms and going into the comment section, right, that's a lot riskier than going to, an established center. So usually, whether you live in a state that the medical center is located or not, their websites often provide validated, vetted information about the condition and about resources to help.
Right.
And so a couple of resources that come to mind, I had mentioned the My MS Toolkit out of the University of Michigan is a great way to get started of some strategies for helping with sleep and becoming more aware. Sometimes it means taking off the Apple Watch or the Fitbit or turning off the sleep tracking feature. Because if you're waking up every morning and being told your sleep score, whatever that means.
That's funny. I did turn mine off. My husband loves his, and for me, it was more anxious because I'd be like, it was terrible. So I'm like, I don't need that. That's just more stress.
And everybody, again, if it's creating more anxiety, if it's creating more worry, then it's not worth it.
Yeah.
And unless you're working with a healthcare provider who's also monitoring that information.
Right.
So the My MS Toolkit, there's also the Cleveland Clinic has a sleep site that I believe has a web-based CBTI intervention I believe it's publicly accessible, but you can certainly read about it and learn more about it. So that, again, really vetted, solid information. They've done a couple clinical trials specifically with people with MS with this program. So that's another great one. So I think those are usually the places to start just to learn more about it.
Perfect.
And that, like I said, the Society for Behavioral Sleep Medicine offers some resources to even start just noticing patterns, right? In the same way with if you're trying to make, if you have a goal for yourself of increasing your physical activity,
right,
you have to start from somewhere and being really honest about where you are currently and not expecting yourself to suddenly be doing something that's way outside of what you've been doing for the past however long you've been doing it. And sleep is the same way, right? These habits don't change overnight, literally.
Right.
They can happen very quickly with CBTI, but not in one night. So it's giving that patience with yourself and knowing that this is a habit, and that if you were completely willing to change your diet from something you've been doing for 5 years to changing now, sleep is another health behavior like that. So giving yourself that grace and patience.
Yes. No, I love that, Abby. And if someone wanted to get a hold of you and they were near you, what are some ways that I know I can get a hold of you on Twitter, but so what are some ways that they can get a hold of you?
Sure. Twitter is great, and especially for just a big public audience like this. If you have questions and want additional resources, and then I don't give medical advice over Twitter or anyone who we don't have an established treatment relationship with, but certainly I can help connect people. And again, there is this growing network of health psychologists, rehab psychologists who can be found too in your state if you want to be seen in person or through virtual, like through PsyPack. There's a lot more growing opportunities there.
Yes. I love that. Well, Abby, I so appreciate you coming out and talking about these things with me, because it's just something that I hear so much of in our MS society and in the chronic world in general. So when I do work with my autoimmune clients, not just MS. So I appreciate you making sure to point that out, that this isn't always just an MS thing. It's for a lot of our autoimmune diseases, a lot of the chronically ill people that deal with this. And now my last question is, do you find that sleep issues are more prevalent with women or men?
I can speak to my patient population and then more broadly. Women tend to present to treatment more frequently, particularly for insomnia. And in general, that is aligned more with general mental health care. Is at the present, again, this is probably just because of bias about mental health treatment in general. So, who comes to clinic is not necessarily the same as asking how prevalent or how common it is. But obstructive sleep apnea tends to be more even in terms of the split between men and women. But there's so many variables that go into that.
Sure. I'm sure there is something for another time. But I definitely, I'm always interested in that because I have as many women as I have men. And so I do find that very fascinating, the differences. But this was wonderful, and I'm sure it's going to help many. And I would love to work with you later when we're working with some of the MS groups and the support group. That would be wonderful to have you on. And
thank you so much.
I just really appreciate the time that I got to be with you, and I got to finally meet you in person, sort of virtually, but just to be able to see you and talk with you and just learn some more about different options we have for sleep and different things we can go to. So I really appreciate that very much, Abby.
Well, thank you for everything you're doing to get the word out and helping people be more aware of what resources may be available to them that they're not aware of, because that sometimes just the awareness itself can make a huge difference in someone's life. So thank you for having me on.
Thank you. And so for all of you, thank you guys for another week of Move It or Lose It. I hope you get a lot of this. I hope you really got a lot of what Abby was talking about. Don't be afraid to rewind, listen to it again. I know with some of my podcasts that I'm enjoying, I want to rewind, go back again and listen. So feel free to do that. And hope you enjoyed this time. So appreciative for Abby to be on with us and help give us a little bit more clarification about what it is that we're struggling with and different options than just medication. So again, have a great week, guys. It was so wonderful to be able to do this recording and this interview with Abby. Have a great week, and I'll see you again next week.